Okay, so good morning. I am Dr. Neelam Bagwale, Assistant Professor at Index Medical College in Gynae Department. So today's topic is physiological changes during pregnancy. So what happens with the genital organs, the vulva, vagina? Okay, so in the vulva, it becomes edematous and more vascular. Superficial varicosities may appear, especially in multipara. Labia minora are pigmented and hypertrophied. Vaginal walls become hypertrophied, edematous, and more vascular. Increased blood supply of the venous plexus surrounding the walls give bluish discoloration of the mucosa, that is Jacquemin's sign. The secretions become copious, thin, and curdy white due to the marked exfoliated cells and bacteria. The pH becomes acidic 3.5 to 6 due to more conversion of glycogen into lactic acid by Lactobacillus acidophilus, consequent on high estrogen level. Cytology, there is preponderance of navicular cells in clusters, small intermediate cells with elongated nuclei. So the changes in the uterus, there is increase in the growth and enlargement of the uterus. Enlargement, the changes in the muscles are hypertrophy and hyperplasia. These occur under the influence of hormones, that is estrogen and progesterone, limited to these changes are limited to the pregnancy, but now limited to first half of pregnancy, but it is pronounced up to 12 weeks. So stretching, the muscles further elongate beyond 20 weeks due to distension by the growing fetus. Arrangement of the muscle fibers. There are three distinct layers of muscle fibers: the outer longitudinal, inner circular, and intermediate. The outer longitudinal it follows a hood-like arrangement over the fundus, and some fibers are continuous with the round ligament. As you can see on the diagram, the inner circular layer is scanty and sphincter-like arrangement around the tubal orifices and internal os. Intermediate layer, it is the thickest and strongest layer arranged in crisscross fashion through which the blood vessels run. A position of two double curved muscle fibers give the figure of 8 form. Thus, when the muscles contract, they occlude the blood vessels running through the fiber and hence called living ligature. The vascular system, there is marked spiraling of the arteries reaching the maximum at 20 weeks. Thereafter, they straighten out. Doppler velocimetry, it has shown uterine artery diameter becomes double and blood flow increases by 8-fold at 20 weeks of pregnancy. This vasodilatation is mainly due to estradiol and progesterone. The veins becomes dilated and are valveless. Shape, non-pregnant pyriform shape is maintained in early months. It becomes globular at 12 weeks. Lateral obliquity, as the uterus enlarges to occupy the abdominal cavity, it usually rotates on its long axis to the right, that is dextrorotation. Contractions is known as Braxton Hicks contractions. It is irregular, infrequent, spasmodic, painless, without any effect on dilatation of the cervix. Near term, the contractions become frequent with increase in intensity so as to produce some discomfort to the patient. Ultimately, it merges with the painful uterine contractions of labor. In abdominal pregnancy, Braxton Hicks contractions is not felt. During contractions, There is complete closure of the uterine veins with partial occlusion of the arteries in relation to intervillous space, resulting in stagnation of the blood in the space. This diminishes the placental perfusion, causing transient fetal hypoxia, which leads to fetal bradycardia coinciding with the contractions. Isthmus, as you can see on the diagram, during the first trimester, the isthmus hypertrophies and elongates to about 3 times its original length. It becomes softer with advancing pregnancy beyond 12 weeks. It progressively unfolds from above downwards until it is incorporated into the uterine cavity. The circularly arranged muscle fibers in the region function as sphincter in early pregnancy, thus helps to retain the fetus within the uterus. Incompetency of the sphincteric action leads to mid-trimester abortions, and the insert-large operation done to rectify the defect is based on the principle of restoration of the retentive function of the isthmus. Now what happens to the cervix is the stroma becomes hypertrophied and hyperplasia of the elastic and connective tissue fibers in the stroma. The fluids accumulate inside and in between the fibers. Vascularity is increased, especially beneath the squamous epithelium of the portio vaginalis, which is responsible for its bluish coloration. There are marked hypertrophy and hyperplasia of the glands, which occupy about half the bulk of the cervix. All these lead to marked softening of the cervix, that is Goodell sign, which is evident as early as 6 weeks. It begins at the margin of the external os and then spreads upwards. Now, the changes over the epithelium is there is marked proliferation of the endocervical mucosa with downward extension beyond the squamo-columnar junction. This gives rise to clinical appearance of ectopy or erosion of the cervix. Sometimes the squamous cells also become hyperactive and the mucosal changes simulate basal cell hyperplasia or cervical intraepithelial neoplasia. These changes are hormone-induced, that is estrogen, and regress spontaneously after delivery. Fallopian tubes at term, its attachment to the uterus is placed at the lower end of the upper 1/3 because of marked growth of the fundus. Changes in the ovaries are, it looks bright orange, later on becomes yellow and finally pale. Regression occurs following decline in the secretion of HCG from the placenta. Colloid degeneration occurs at 12th week, which later becomes calcified at term. Hormones, estrogen and progesterone, secreted by the corpus luteum, maintain the environment for the growing ovum before the action is taken over by the placenta. These hormones not only control the formation and maintenance of decidua of pregnancy, but also inhibit ripening of the follicles. Thus, both the ovarian and uterine cycles of the normal menstruation remain suspended. Luteoma of pregnancy results from exaggerated luteinization reaction of the ovary. Decidual reaction, there may be patchy sheet of decidual cells on the outer surface of the ovary. These are metaphasic changes due to high hormonal stimulation. The same stimulus may also produce luteinization of atretic or partially developed follicles. So the changes in the breast are best evident in the primary gravida. The size, there is increased size of the breast becomes evident even in early weeks. This is due to marked hypertrophy and proliferation of the ducts that is due to estrogen, and alveoli, that is both estrogen and progesterone dependent, which are marked in peripheral lobules. Myoepithelial cells become prominent. Vascularity is increased, which result in appearance of bluish veins running under the skin, quite often the axillary tail. The nipples and areola, the nipples becomes larger, erectile, and deeply pigmented. Variable number of sebaceous glands, 5 to 15, which remain invisible in the non-pregnant state in the areola, becomes hypertrophic and are called Montgomery tubercles. An outer zone of less marked and irregular pigmented area appears in second trimester and is called secondary areola. Cutaneous changes. The face shows chloasma gravidarum or pregnancy mask. It is an extreme form of pigmentation around the cheeks, forehead, and around the eyes. Abdomen shows linea nigra and stria gravidarum. The linea nigra, it is a brownish black pigmented area in the midline stretching from the xiphisternum to the symphysis pubis. The pigmentary changes are probably due to melanocyte stimulating hormone from the anterior pituitary. However, estrogen and progesterone may be related to it as similar changes are observed in women taking oral contraceptive pills. The pigmentation disappears after delivery. Stria gravidarum. These are the stretch marks that represent the scar tissue in the deeper layer of the cutis. Initially, these are pinkish, but after delivery, the scar tissue contract and obliterate the capillaries, and they become glistening white in appearance and are called stria albicans. Now, weight gain. The total weight gain during the course of a singleton pregnancy for a healthy woman averages 11 kg. So the weight is, the fetus weight is around 3.3 kg, placenta 0.6 kg, liquor is 0.8 kg, uterus is 0.9 kg, breast is 0.4 kg, accumulation of fat and protein is 3.5 kgs, increase in blood volume to about 1.3 kgs, increase in extracellular fluid to about 1.2 kgs. So the causes of increased sodium retention during pregnancy are increased estrogen and progesterone, increased aldosterone, consequent on the activation of renin-angiotensin system, and possibly due to increased antidiuretic hormone. The amount of water retained during pregnancy at term is about to be 6.5 liters. Importance of weight gain. The rapid gain in weight of more than 0.5 kg 1 lb a week or more than 2 kg 4 lb a month in later month of pregnancy may be the early manifestation of preeclampsia and needs for careful supervision. Stationary or falling weight may suggest intrauterine growth retardation or intrauterine death of the fetus. Body water metabolism. During pregnancy, the amount of water retained at term is about 6.5 liters. Pregnancy is a state of hypervolemia. The important causes of sodium retention and volume overload are changes in maternal osmoregulation, increased estrogen and progesterone, increase in renin-angiotensin-aldosterone system activity, increase in aldosterone, deoxycorticosterone, controlled by arginine vasopressin from posterior pituitary and atrial natriuretic peptide, serum sodium level and plasma osmolality decreases. Hematological changes. The blood volume During pregnancy, there is increased vascularity of the enlarging uterus with the interposition of uteroplacental circulation. The blood volume starts to increase. The blood volume starts to increase from about 6th week, expands rapidly thereafter to maximum 40 to 50% above the non-pregnant level at 30 to 34 weeks. So the principal blood changes during pregnancy. In pregnancy near term, the blood volume becomes 5,500 ml, as in the non-pregnant state, it is 4,000 ml. The increase in plasma volume by 3,750 ml from 2,500 ml in non-pregnant state. The red cell volume increases by 1750 ml from 1400 ml in non-pregnant state, and the total hemoglobin is about 560 grams near term, and the hematocrit becomes 32% near term. So the changes are the changes in the blood volume is around 40%, plasma volume is around 50%, red cell volume is about 30%, total hemoglobin is about 20%, hematocrit is, the level of hematocrit is diminished during pregnancy. So the red blood cell mass has increased to the extent of 30%. The total increase in the volume is about 350 ml. This increase is regulated by the increased demand of oxygen transport during pregnancy. Total protein, the total plasma protein increases from normal 180 non-pregnant level to 230 grams at term. However, due to hemodilution, the plasma protein concentration falls from 7 grams to 6 grams. This results in diminished viscosity of blood and reduced colloid osmotic tension. Because of marked fall in albumin level from 4.3 grams percent to 3 grams percent, a fall of about 30%, and only slight rise of globulin, mainly a globulin, the normal albumin globulin ratio of 1.7:1 is diminished to 1:1. So the plasma protein changes during pregnancy are the total proteins are increased, the plasma protein concentration are decreased, albumin is decreased, globulin is slightly increased, and albumin globulin ratio is decreased. So the blood coagulation factors during pregnancy. Pregnancy is a state of hypercoagulable state. The fibrinogen level is raised by 50% from 200 to 400 milligrams per dl in non-pregnant to 300 to 600 milligrams per dl in pregnancy. As a result of rise in fibrinogen and globulin level and diminished blood viscosity, erythrocyte sedimentation rate gives a much higher value during pregnancy. As such, ESR has got little diagnostic value in pregnancy. Gestational thrombocytopenia may be due to hemodilution and increased platelet consumption. The levels of coagulation factors normalize 2 weeks postpartum. The changes in blood coagulation factors, the platelets are static or 15% reduction in the count. Fibrinogen level is increased by 50%. The fibrinolytic activity is depressed in pregnancy near term. The clotting time is unaffected and the ESR is marked increased 4 times during pregnancy. RBC mass is increased. So now what happens to the cardiovascular system due to elevation of the diaphragm consequent to the enlarged uterus, the heart is pushed upwards and outwards with slight rotation to the left. A systolic murmur may be audible in the apical or pulmonary area. This is due to decreased blood viscosity and torsion of the great vessels. A continuous hissing murmur may be audible over the tricuspid area in the left, second, and third intercostal spaces called the mammary murmur. It is due to increased blood flow through the internal mammary vessels. Doppler echocardiography shows an increase in left ventricular and diastolic diameters. A third heart sound due to rapid diastolic filling, and rarely a fourth heart sound may be auscultated. ECG reveals normal pattern except evidences of left axis deviation. The physician should be familiar with these physiological findings. What happens to the cardiac output is the cardiac output starts to increase from 5th week of pregnancy and reaches its peak by 40 to 50% at about 30 to 34 weeks. Thereafter, the cardiac output remains static till term when the observation is made at lateral recumbent position. The cardiac output is lowest in the sitting or supine position and highest in the right or left lateral or knee chest position. The cardiac output increases further during labor and immediately following delivery by 70% over the pre-labor values. So the MAP, mean arterial pressure, also rises. There is squeezing out of the blood from the uterus into the maternal circulation. This is known as autotransfusion during labor, and in immediate postpartum, cardiac output returns to pre-labor values by 1 hour following delivery and to the pre-pregnant level by another 4 weeks' time. Blood pressure, in spite of large increase in cardiac output, the maternal BP is decreased due to decrease in systemic venous resistance. There is overall decrease in diastolic blood pressure and mean arterial pressure by 5 to 10 millimeters mercury. The decrease in maternal blood pressure parallels that of SVR. So the antecubital venous pressure remains unaffected. Femoral venous pressure is markedly raised, especially in later months of pregnancy. It is due to pressure exerted by the gravid uterus on the common iliac veins, more on the right side due to dextro-rotation of the uterus. The femoral venous pressure is raised from 8 to 10 centimeters of water in non-pregnant state to about 25 centimeters of water during pregnancy in lying down position, and to about 80 to 100 centimeters of water in a standing position. This explains the fact that the physiological edema of pregnancy subsides by rest alone. Distensibility of the veins and stagnation of blood in the venous system explain the development of edema, varicose veins, piles, and deep vein thrombosis. So, supine hypotension syndrome, also known as postural hypotension. So during late pregnancy, the gravid uterus produces a compression effect on the inferior vena cava. When the patient is in supine position, results in opening up of the collateral circulation by means of paravertebral and azygous veins. In some cases, when the collateral circulation fails to open up, the venous returns of the heart may be seriously curtailed. This results in production of hypotension, tachycardia, and syncope. The normal blood pressure is quickly restored by turning the patient to lateral position. The augmentation of venous return during uterine contraction prevents the manifestation from developing during labor. So, regional distribution of blood flow. The uterine blood flow is increased from 50 ml per minute in non-pregnant state to about 750 ml near term. The non-pregnant uterus receives 2% of carbon monoxide and breast 1%. Increase in blood flow going to the organs is about non-pregnant uterus receives 2% of cardiac output and breast receives 1%, and increase in blood flow going to the organs is about 50% due to overall increase in cardiac output. The increase is due to combined effect of uteroplacental and fetoplacental vasodilatation. The vasodilatation is due to smooth muscle relaxing effect of the progesterone, estrogen, nitric oxide, prostaglandins, and atrial natriuretic peptide. So in a normal pregnancy, the vascular system becomes refractory to angiotensin 2, endothelin 1, and other pressure agents. Pulmonary blood flow is increased by 2500 ml per minute. Renal blood flow is increased by 400 ml per minute and remains at this level till term. The blood flow through the skin and the mucous membrane reaches a maximum of 500 ml per minute, and heart sensation, sweating, heat sensation, sweating, or stuffy nose complained by the pregnant woman can be explained by increased blood flow. The metabolic changes, protein metabolism. There is a positive nitrogenous balance throughout pregnancy. At term, the fetus and the placenta contain about 500 grams of protein, and the maternal gain is also about 500 grams, chiefly distributed in the uterus, breast, and maternal blood. As the breakdown of amino acid to urea is suppressed, the blood urea level falls to 15 to 20 milligram per cent. Blood uric acid and creatinine level, however, either remain unchanged or fall slightly. Amino acids are actively transported across the placenta to the fetus. Pregnancy is an anabolic state. Carbohydrate metabolism. Transfer of increased amount of glucose from mother to the fetus is needed throughout pregnancy. Insulin secretion is increased in response to glucose and amino acids. There is hyperplasia and hypertrophy of beta cells of pancreas. Sensitivity of the insulin receptors is decreased, especially during later months of pregnancy. Plasma insulin level is increased due to a number of contra-insulin factors. These are estrogen, progesterone, human placental lactogen, cortisol, prolactin, free fatty acids, leptin, and TNF-alpha. There is increased tissue resistance to insulin. This mechanism ensures continuous supply of glucose to the fetus. The overall effect is maternal fasting hypoglycemia and postprandial hyperglycemia and hyperinsulinemia. The oral glucose tolerance test may show an abnormal pattern. This helps to maintain a continuous supply of glucose and free fatty acid to the fetus. So what happens to the lipid metabolism? The total lipid level is increased by 50%. LDL and cholesterol is also increased by 40%. The HDL level is also increased by 15%. That is a good sign. Triglyceride level are increased by 50%. So the HDL level increases by 15%. LDL is utilized for placental steroid synthesis. This hyperlipidemia of normal pregnancy is not atherogenic. The activity of lipoprotein lipase is increased. Leptin, a peptide hormone, is secreted by adipose tissue and placenta. It regulates the body fat metabolism. So what happens with the iron metabolism? The iron absorption is in ferrous form from the duodenum and jejunum and is released into the circulation as transferrin. About 10% of the ingested iron is absorbed. Iron freed from transferrin is incorporated into hemoglobin and myoglobin as or stored as ferritin or hemosiderin. The iron is transported actively across the placenta to the fetus. The iron requirement during pregnancy is considerable and is mostly limited to the second half of pregnancy, especially to the last 12 weeks. Total iron requirement during pregnancy is estimated approximately 1000 milligrams. This is distributed in fetus and placenta 300 milligram and expanded red cell mass 400 milligram. There is a obligatory loss of about 200 milligram through the normal routes. The iron in the fetus and placenta is permanently lost and a variable amount of iron in the expanded RBC volume is also lost. Okay. There is obligatory loss of 200 milligram through the normal routes. In the absence of iron supplementation, there is a drop in hemoglobin, serum iron, and serum ferritin concentration during pregnancy. Thus, pregnancy is an inevitable iron deficiency state. Systemic changes, respiratory system, the subcostal angle increases from 68 degrees to 103 degrees in the transverse diameter of the transverse diameter of the chest is expanded by 2 centimeters and the chest circumference increases by 5 to 7 centimeters. The mucosa of the nasopharynx becomes hyperemic and edematous. This may cause nasal stuffiness and rarely epistaxis. A state of hyperventilation occurs during pregnancy, leading to increase in tidal volume and therefore respiratory minute volume by 40%. It is probably due to progesterone acting on the respiratory center and also to increase in sensitivity of the center to carbon dioxide. The woman feels shortness of breath. The urinary system, kidney. There is dilatation of the ureters, renal pelvis, and the calyces. The kidneys enlarge in length by 1 centimeter. Renal plasma flow is increased by 50 to 75%, maximum by 16 weeks, and is maintained until 34 weeks. Thereafter, it falls by 25%. The GFR is increased by 50% all throughout pregnancy. Increased GFR causes a reduction in maternal plasma levels of creatinine, blood urea, nitrogen. Ureter becomes atonic due to high progesterone level. Dilatation of the ureter above the pelvic rim with stasis is marked on the right side, especially in primigravida. The stasis is marked between 20 to 24 weeks. There is a marked hypertrophy of the muscle and the sheath of the ureter, especially the pelvic part, probably due to estrogen. There is elongation, kinking, and outward displacement of the ureter. Bladder, there is increased frequency of micturition at 6 to 8 weeks of pregnancy, which subsides after 12 weeks. It may be due to resetting of osmoregulation, causing increased water intake and polyuria. In late pregnancy, frequency of micturition once more reappears. So what happens with the liver and gallbladder? Although there is no histological change in the liver cells, but the functions are depressed. With the exception of raised alkaline phosphatase level, other liver function tests like serum, bilirubin, AST, ALT, CPK, LDH enzymes are unchanged. The nervous system, postpartum blues. What happens to the nervous system? This is especially important because many of the patients are suffering from postpartum psychosis and depression. So the postpartum blues, depression or psychosis may develop in a susceptible individual. Compression of the, this is due to compression of the median nerve underneath the flexor retinaculum over the wrist joint, leading to pain and paresthesia in the hands and the arm. This is known as carpal tunnel syndrome, may appear in the later months of pregnancy. So what happens in the later months of pregnancy to the nervous system is postpartum blues, depression and psychosis and carpal tunnel syndrome. Similarly, paresthesia and sensory loss over the anterolateral aspect of the thigh may occur. It is due to compression of the lateral cutaneous nerve of the thigh. What happens to the calcium metabolism in skeletal system during pregnancy? There is increased demand of calcium by the growing fetus, which is required in the last trimester, especially for the fetal bone mineralization. So daily requirement of the calcium during pregnancy and lactation is around 1 to 1.5 grams per day. Maternal total calcium levels fall, but the serum ionized calcium level is unchanged. 50% of the serum calcium is ionized, which is important for physiological function. Calcium absorption from intestine and kidneys are doubled due to rise in the level of 1,25-dihydroxy vitamin D3. Pregnancy does not cause hyperparathyroidism. Calcitonin level increased by 20%. Calcitonin protects the maternal skeleton from osteoporosis. Maternal serum phosphate level is unchanged. Thank you.